Let's quickly review of the lower limb, which we already have done, like the soft tissues and this particular relevant thing, which is elements of the lower limb, which I just want to quickly review of the things, like starting with the lower limb fascia, which consists of the two layers, superficial and the deep layer. We call them as fascia lata. Fascia lata in this deep fascia, which is present in the thigh region, whereas in the leg region we call them as fascia cruris. Now, this particular fascia lata has an attachment above, and it is having attachment on all the bony prominences which is present in this particular groin region, like inguinal ligament, bony pubis, bony pubic tubercle, posterior iliac crest, etc., etc. And it is continued downwards as well, like in the leg region, as a deep fascia of the leg. Now, the fascia lata splits this particular thigh region into three quadrants: anterior, medial, and posterior. A special condensation of the fascia lata, we call them as iliotibial tract, which is basically lateral part of this particular thickened fascia lata. And this particular fascia lata, iliotibial tract, has an attachment below in this particular tubercle. We call them as lateral condyle of the tubercle, where it is attached. Into this particular iliotibial tract, a muscle inserts or attaches to it. We call them as this tensor fascia lata and a part of gluteus maximus, which is attaching to it. In this thigh region, the deep fascia has an opening. We call them as this opening as a saphenous opening, which is guarded by a cubiform fascia. Cubiform plate, we call them as cubiform fascia. Piercing through this particular opening in this particular medial side of the upper end of the fascia lata comes is great saphenous vein, which dives in and opens into this deep vein. We call them as femoral vein. Now, this region, we have two sets of veins, superficial deep. Connecting between them, we have a perforated vein, superficial vein. We have two of them are of notation, GSV and SSV, great saphenous vein and small saphenous vein. Deep vein, which is any other vein like femoral vein, popliteal vein, tibial vein, etc., etc. Communicating between superficial and the deep vein, we have the perforated veins, which is draining the blood from superficial to the deep veins. The great saphenous vein, you have to know a little bit about detail of it, where it starts from this particular dorsum of the foot, then anchors in front of this medial malleolus, goes posterior to this particular patella, which is like a 100, and empties into the deep vein or deep vein of the leg region. We call them as fascial vein. Piercing through or passing through the opening, we call them as saphenous opening. So, this is about the great saphenous vein, which is accompanied by a superficial cutaneous vein. We call them as superficial cutaneous nerve. We call them as saphenous nerve, which has almost nearly like a same course as this particular great saphenous vein has below this particular leg region. Other than this particular great saphenous vein, we have another vein. We call them a small saphenous vein, SSV, which starts from the lateral side of the lateral malleolus, moves up in the midline of the leg region and ends into popliteal vein or drains into the popliteal vein. Accompanying this particular vein, we have a cutaneous vein. We call them a cutaneous nerve. We call them a sural nerve. Now, joining this particular superficial vein to this particular deep vein, we have a bridging vein. We call them a perforating veins. Blood flow from superficial to deep goes through this particular like a perforating veins. They have a valve which is having a one direction, allowing blood to go from superficial to deep. If by any chance these particular valves are lost, we have a retrograde or reversal flow. That means blood from the deep vein drains to superficial vein, and the superficial vein becomes engorged, dilated, then call them as varicosity. Coming to the deep vein, they are present in the thigh region like a femoral vein, which drains into external iliac vein. Then we have this particular leg region, tibial vein, and here posterior tibial vein. Backside we have the popliteal vein. These are the like a deep veins. Joining between them, we have this particular superficial vein, and we'll learn about the varicosity, which is the reversal of the blood flow, which normally happens superficial to deep, which can be a reversal because of the valve incompetency. If we have this particular deep veins, may have a sluggish flow of the blood may be clotted in there. That leads to thrombosis. We call them as DVT, deep vein thrombosis. That means the blood which is present within this particular deeper veins of the thigh, leg, etc., etc., maybe just have some sort of coagulative nature, which leads to blood accumulations, blood clotting, which is like this, and we call them as thrombosis. And if this particular thrombosis dislodges or moves out, we call them as embolism. If it is hits this particular pulmonary circulation, we call them as pulmonary thromboembolism. Now coming to this particular use of the saphenous vein, which can be used for the graft. If you are creating a bypass graft, this particular small great saphenous vein especially can be picked up and create a bypass graft like this, and joining this particular coronary arteries, they can create a venous graft. Coming to this particular lymphatic drainage, we have this particular lymphatic drainage in this leg region located over this particular groin region. We call them as inguinal group of lymph nodes. There are two sets, superficial and deep. Superficial are divided into two groups, vertical group and horizontal group. This group we call them as horizontal group, this group we call them as vertical group. Vertical group receives the lymphatics from all this medial side and the anteromedial side, and as well as this whole of this thigh region. So all this region drains to this medial group, this vertical group of superficial inguinal lymph nodes. This horizontal group receives the lymphatics from the anterior abdominal wall, glutes region and groin region, as well as and from the organs or these genitalia, etc. Lymphatics from the superficial group drains to the deep group, from the deep group goes to the deeper group, we call them as ilia group of lymph nodes. They are also superficial and deep inguinal group of lymph nodes. Likewise, we have this ilia group placed in here like external ilia and internal ilia group of lymph nodes. On the back side, we have a venous lymphatic, we call them as popliteal vein or popliteal lymphatic system, which is present in this particular popliteal fossa. It receives the back side of the cuff region or the back side of the leg region lymphatics from that particular part. So this particular lymphatic drainage can be enlarged in case of the diseases of these particular draining areas like anterior abdominal wall or glute region or perineum or external genitalia or the leg region, infections, malignancy, etc., etc. So we call them as enlarged inguinal lymph node or enlarged inguinal lymph node. Coming to the cutaneous innervations, we have the number of nerve supply to this particular leg region. Like in the thigh region, we have these three sets of the vein nerves: medial cutaneous nerve of thigh, lateral cutaneous nerve of thigh, intermediate cutaneous nerve of thigh, and then we have this particular branch we call them as iliotibial nerve, which supplies over there. We have the genitofemoral, which supplies in this particular region as well as over this thigh and this groin region. Lower part, we have these two veins which is taking part. We call them as saphenous nerve, and as well as the sural nerve taking care of the back side, and then we have the superficial fibular nerve taking care on the lateral side. And in this particular foot region as well, we have the deep fibular nerve, which is supplying in this particular web space between this big toe and this next toe, which is the second toe, and rest of this is supplied by this lateral cutaneous nerve of thigh, lateral cutaneous nerve of foot, which is a branch of the superficial fibular nerve. So this is how this particular cutaneous innervation goes in this region. The nerve supply and this particular innervations, we have to so we have these muscles which is related to this hip joint. We call them as flexures of the hip, and this flexure of the hip present in the front side, which is known as the iliopsoas and pectineus. They are strong muscles coming from this posterior abdominal wall moving to front, and they are helping to bend this particular hip joint. We call them as flexure of the hip joint. And iliotibial pectineus is the largest horn which is taking care of this, and assisted by the sartorius, which is the anterolateral compartment muscle of the thigh region, which is present in this region, running across from anterior superior iliac spine to this region. Then we have this particular muscle in the front of the thigh region. We call them as quadriceps muscle, like vastus, 3 of them, and rectus femoris. And quadriceps femoris makes a tendon, we call them patellar tendon, and this particular patellar tendon anchors to this particular front of the tibia, which is known as tibial tuberosity. So these 4 tendons makes this particular quadriceps femoris or quadriceps tendon, and present in the front of the thigh region once as or acts as the extension of the knee joint. Whenever this particular knee jerk is elicited, this particular muscles are contracting and knee jerk is produced. Now coming to this particular medial compartment, which is called as all the adductors like longus, brevis, magnus, which is like deeply placed, like superficial to deep. Longus is a long, brevis is a small, deep to longus we have the brevis, and most deepest is the magnus. And in the medial compartment also we have this scilly muscle, we call them as gracilis, and obturator externus, which is a tiny medial muscle, which is basically rotator muscle of the hip region. Out of these particular adductor muscles, adductor longus and brevis, you should be able to identify this in a specimen. Adductor magnus, which is the largest muscle, have got holes in them. We call them as foramens, which is present in the adductor magnus. The perforators, which is present in this region, perforates through the adductor magnus, goes to this particular front side to this back side of the thigh region. Now, coming to this particular tendon reflex that we have mentioned many a times in the physiology, also we have to do this particular knee jerk tendon reflex. If you tap in front of this patellar tendon, this particular knee just like a shoots, or kind of like a knee jerk happens, or kind of like a extension of the knee happens because of the contractions of this particular front of this particular thigh muscle, which is quadriceps muscles. And these particular muscles are supplied by the femoral nerve. The femoral nerve has a root value of this L2, L3, L4. That means if this particular knee jerk is perfectly elicited, that means this nerve which is supplying to these particular muscles, that need femoral nerve, and the segment of the spinal cord which is coming from this region, which is L2, L3 and L4, is perfectly fine and working well. Now, coming to this particular anatomical landmark over here in the femoral triangle, we have to know this particular boundaries of it: medial boundary, lateral boundary, superior boundary, inguinal ligament, sartorius, and this particular adductor longus, which is making this. And content of this particular femoral triangle is this particular three content: femoral artery, femoral nerve, femoral artery, femoral vein, lateral to medial, they are placed, and the branches from arteries and the nerves which are present to it. So, these particular element that we have to keep in mind regard to this particular femoral triangle. Now, this particular femoral triangle have got little bit like a kind of special feature which we call them as the femoral canal, which is like a medial compartment or medial most compartment of this of the femoral triangle. We call them as femoral canal, which is basically like having a communications with this particular abdominal content or peritoneum. So, this particular boundary of the femoral canal that you have to know where exactly, which is this femoral canal, which is present in the medial side of this femoral triangle, and the opening of the femoral canal we call them as femoral ring. Femoral ring has a boundary like anteriorly inguinal ligament, posteriorly by this pectineal ligament, which is basically fragment which is coming from the pectineus muscle, and medially by this lacunal ligament, which is basically continuation of the inguinal ligament. So, three ligaments, inguinal, pectineal and lacunal ligament bounding it, and this particular ring which is having a ring shaped support structure which is lying in this region. Content of this particular femoral canal is basically occupied by the lymph node. We call them as deep inguinal group of lymph node or lymph node of the clocket that we have to learn over here. Now, this particular point, through this particular ring, the abnormal content may get in. We call them as femoral hernia. This femoral hernia commonly can be peritoneum, would be like content of the small intestine or anything else which may be getting in through this particular femoral canal through this particular femoral ring. And this particular femoral hernia pretty much common in the female because of the having a roomy pelvis, because of this region which has like a space which is little bit more. So, whenever you are going to see this particular femoral region, read these particular regions. Coming to this particular mid portions of the thigh, we have another space, we call them as adductor canal, also known as Hunter canal, subarterial canal, which is basically the middle portions of the thigh region and having some kind of content and this boundary over there, which is superiorly bounded by this particular lower limit of this particular femoral triangle, and inferiorly it terminates with this particular opening or fifth opening of this particular adductor magnus, and posteriorly it is lying by over here adductor longus magnus, which is lying in making the floor of here, and medially it is occupied by the sartorius, which is coming on lateral to medial, and laterally by the vastus lateralis. So, these are the boundaries that we should be knowing about the sartorial canal, and the content which is of course the femoral artery or femoral vessels, and the nerve which is coming from this particular femoral nerve, which is known as saphenous nerve, which is giving a cutaneous branch, and a motor branch which is known as nerve to vastus medialis, along with the lymphatics which is present in it. So, adductor canal that we will be knowing over here. Talking about the artery, femoral artery, which is a continuation of the external iliac artery. So, we have this abdominal aorta splits into external and internal branch. External abdominal aorta continued below this particular external iliac artery continued below this particular inguinal ligament is named as femoral artery. Femoral artery present in the femoral triangle, then adductor canal. Then this particular thing pierces this particular fifth osteoaponeurotic opening of the adductor magnus, goes in the region, change the name, becomes the popliteal artery, then popliteal artery splits, becomes this particular posterior tibial artery, anterior tibial artery, like this. So this is the same radiograph which you are seeing here, which is known as arteriogram, which is showing the course of this particular like abdominal aorta to this particular iliac artery to this particular femoral artery to popliteal artery, so on. Now, deep artery of the thigh, which is a branch coming from this particular femoral artery, which is present in this particular femoral triangle, and this particular artery, deep artery, also known as arteria profunda femoris, gives this particular perforator branches which pierces this adductor magnus, supplies the thigh regions over this region. Along with this particular like arteria profunda femoris, this arteria profunda femoris gives two important branches, we call them as circumflex branches, medial circumflex and lateral circumflex. This circumflex around this particular hip joint and supplies this particular hip joint region with the blood. Obturator artery, which is a branch of like internal iliac, goes down and serves the medial compartment of the thigh, supplies this particular nerve and artery there. Femoral vein, which is a continuation of the popliteal vein which is formed by the union of the tibial vein. Now, popliteal vein pierces this particular fifth osteoaponeurotic opening over this particular thigh region, which is also known as adductor hiatus, and then comes to this front compartment in this particular region, we call them as hunter canal. Then it enters to the femoral triangle, and then this particular thing drains to the iliac group of veins which is present. Into this particular femoral vein, it receives one tributary of this superficial vein, we call them as GSV. So, this is about this particular femoral vein that you have to know. This is a clinical importance that we sometimes ask about in examinations, like a psoas abscess, which is a kind of like a landmark anatomy that you have to know. Sometimes we have this particular infections of the vertebra, and this particular vertebral infections, which is infections of the vertebra, is created or caused by a tubercular germ, we call them as tubercular osteomyelitis, that create a pus. We call this as a tubercular pus, and this particular pus, if it is occupied in this particular lumbar region, affecting in this particular lumbar vertebrae, the pus may trickle down because of the gravity, and this particular pus follows the psoas fascia, and following the psoas fascia trickles down through this particular posterior abdominal wall, then it moves to the anterior abdominal wall, and then it settles down to the groin region. So, this particular groin region swelling presents as an abscess or swelling. So, this particular abscess is a cold abscess because they do not have signs of pain or inflammations. So, this particular cold abscess is a kind of like important landmark which basically helps us to identify the territorial anatomy of this particular psoas major muscle, which is attached to this particular lumbar vertebra covering this. We have the psoas fascia, and the psoas major muscle is anchored to this particular tibia, anchored to this particular upper end of this particular femur. We call them as lesser trochanter, so as a iliopsoas. So, as this particular psoas muscle is inserted into this particular lesser trochanter, this pus which is draining along this particular psoas muscle can also trickle down and settle to this groin region. So, this is known as psoas abscess. Basically, it is happening in this particular like a lower back region, but presenting in this groin region as psoas abscess, because psoas muscle in this groin region is visible, which is a chief hip flexors, as we have mentioned. Coming to the nerve, which is starting in this nerve which is present in the region, which is coming from the lumbar plexus, which is formed by this particular number of nerves like L1, L2, L3, L4 and branch of L5, which is basically making a network and giving right so many of nerves like ilio-inguinal, ilio-hypogastric, genitofemoral. All these nerves are visible in the posterior abdominal wall. They are exam tags. Whenever you are examining practical exam, we identify that. And as well as it has this particular mixed nerve like a femoral nerve, obturator nerve, and this particular nerve which is coming in this particular region serves this particular anterior compartment of the thigh and medial compartment of the thigh region, which is supplying to this particular region. So you should be knowing these particular nerves of this particular femoral nerve, which is a kind of mixed nerve. Predominantly it is a kind of like a nerve which is going to supply the muscles, supplies all the muscles which is present in the front of the thigh regions, which is anterior compartment thigh, and then it aims to supply this particular knee joint, supplies this particular proprioceptions or joint position vibration cells. And this particular femoral nerve splits down to a cutaneous branch. We call them as saphenous nerve. Saphenous nerve is a cutaneous branch. That's why we call them as this nerve as like mixed kind of nerves. So it supplies the muscles. It supplies this particular rectus muscles and the vasti, that means quadriceps muscles. It supplies the skin. It supplies this particular joint like knee joint, and it also gives a tweak to hip joint as well. So it has articular branch, muscular branch, cutaneous branch, etc., etc. So this is how you are studying. Should be revising. Obturator nerve, which is another branch of lumbosacral region. Of course, this particular nerve is as well having the same domain, which is coming from this particular region. Obturator nerve, which is having a kind of the same innervations, which is going to supply this particular muscle, obturator internus, obturator externus, and as well as supplies this particular adductor group of muscles, which is present in the adductor regions of the thigh regions. Coming to other muscle, cutaneous muscle, out of this lateral cutaneous nerve of thigh, which is coming from this region, piercing to the inguinal ligament, which enters to this particular thigh region, supplies the skin of the lateral part of the thigh. Sometimes this particular, as it is piercing this particular inguinal ligament, this lateral femoral cutaneous nerve of thigh may be trapped, and that particular trapped nerve may create a pain sensation. We call them as Meralgia Paresthetica, which is a kind of like a cutaneous sensory innervations or sensory innervating region may feel some kind of paresthesis. That means abnormal touch pain temperature sensation, which is a kind of like a common clinical presentation. So Meralgia Paresthetica is just kind of like lateral cutaneous nerve. It may be trapped under this inguinal ligament as it is coming to the close relationship over there. So this is about this particular nerve and the anterolateral compartment of this particular thigh region. Nerve supply, blood supply likewise. So we have the gluteal muscle, which is like a bulky muscle. Superficially we have this particular muscle, we call them as glute max, which along with this help by this tensor fascia lata, which is a important muscle in terms of supporting this hip joint is concerned. This muscle basically pulls this particular hip joint back or posteriorly. If you are just raising your leg back side, that means the extension of the hip. If you are making this particular hip joint fold, that means you are doing flexion. So these muscles are working on the back side. They are known as extensors of hip. And this particular extensors of the hip is prime extensor is the glute max or gluteus maximus, which is also assisted by medius and minimus by stabilizing this particular hip joint, also by tensor fascia lata. Now deep layer muscles, which is lying deep to that, this gluteus muscle, we call them piriformis, obturator internus, gemellus superior, inferior, and quadriceps. They are present in this particular deep to this particular region. They are basically working on the back side of the hip joint, and once they contract, they rotate this hip joint laterally. That's why they are known as lateral rotator of the hip. So talking about the glute max, which is kind of like a cheap extension muscle, and as well as it's a cheap climbing muscle. So if you are just climbing upstairs or climbing up uphill, this gluteus maximus is taking most of the time, especially if you are climbing up or raising from the sitting position, this particular gluteus maximus is working. So if this particular muscle becomes weak, we find it difficulty in climbing stairs or climbing uphill or getting up from sitting postures, etc., etc. And as well as we find a loss of balance whenever we are bending down in positions. So gluteus maximus is a large muscle. Deep to that we have the gluteus medius and minimus. Gluteus medius and minimus is largely stabilizing this particular hip joint when this particular hip in a lateral in position, and also rotates this particular thing which is laterally. So basically along with the small tiny rotator muscles, this gluteus medius and the minimus is lateral rotator of the hip joint. Tensor fascia lata, which is present on the side of this, which is inserting on the tensor iliotibial tract, which is coming from this particular lateral side of this gluteus maximus over this region, primarily acts as a hip flexure and in this like helping to bend this particular hip, but as well as it can work as a adductor, a abductor and a medial rotator of the thigh. Iliotibial tract that we have mentioned in the beginning, I'm skipping this part. Posterior compartment of the thigh, they are known as hamstring muscles, semitendinosus, semimembranosus, biceps femoris and adductor magnus. They are kind of like contributing to it. And adductor magnus, which is having a two part, we call them as hamstring part. The hamstring part is basically contributed within this posterior compartment muscle of the thigh or hamstring muscles. And this biceps femoris, which has a short head of the and a long head, they are present in the back side. Out of these four muscles, semitendinosus, semimembranosus, long head of the biceps and this hamstring part of the adductor magnus is included as a hamstring group of muscle. They have a particular character like supplied by the tibial nerve of tibial branch of sciatic nerve. They are extending the thighs, they are flexing the leg, and they have a common origin at ischial tuberosity of bony origin and inserting on the tibia or below this knee joint. So these are the characteristics of hamstring muscles. Now coming to nerve supply of this region, gluteal muscles. So we have this particular muscles in this back supply region comes through this plexus, we call them a sacrocoaxial plexus, which is going to give a number of branches. Likewise, we have seen the lumbosacral plexus, lumbar region or iliolumbar plexus. We have this sacrocoaxial plexus contributing by this particular L4, L5, L so on, S2 up to S5. They are contributing nerve like gluteal nerve, superior, inferior, nerve to piriformis, sciatic nerve, and cutaneous nerve, which is going to supply the back side as well. So this particular muscle, which is coming from the lumbosacral plexus, they are supplying basically back side gluteal region to the back side thigh, leg up to this particular flute region. So this particular region, gluteus, superior gluteal nerve, which is basically supplies gluteus medius and minimus, and inferior gluteal nerve supplies the gluteus maximus. These are the paradox or opposite to this particular nerve that we usually ask about supply to this. Now this gluteal nerve, which is known as superior gluteal nerve, is supplying this gluteus medius and the minimus. It stabilizes the hip joint and as well as lateral rotator. So if this medius and minimus, if it is like weak, if we are standing on one leg, we tend to like raise the opposite side. So normally what happens if you are standing in like one leg, so normal happens over here, the opposite side or unsupported side on which you are standing, that side moves up. That's a normal thing. This is the normal one. So this leg you are standing on, that means this side gluteus medius and gluteus minimus is working and working fine. That because this is supplied by this like intact superior gluteal nerve, and we can stand still, and as a result of this opposite side hip is moving up. That's a normal sign. Now instead of this thing, if it is sagging down, that means this is a Trendelenburg test positive. That means this side is sagging down, that means this is a off balance posture. That means this side into which you are standing like gluteus medius and minimus, which is defective or not working properly, letting this particular hip fall down on the opposite side or unsupported side. That means they maybe have a muscle damage or maybe have a nerve damage which is supplying to it. So superior gluteal nerve or this particular weakness of the gluteus medius and the minimus may be compromised if you have injury to this particular region, and that elicits Trendelenburg test positive, which is an exam question many a times we ask. But we have a prerequisite to test this. So this Trendelenburg should be tested in intact hip joint position. So hip joint, if you have a fracture or anything which is disease of the hip joint, if you have, you cannot perform the Trendelenburg test positive or negative. By doing this test, we cannot come to any conclusions. So it has to be a sound hip joint, and then we can elicit the Trendelenburg test and we can interpret what is happening with this Trendelenburg with the gluteus medius and the nerve supply to it. Inferior gluteal nerve is supplying this glute max. As I am saying, this gluteus maximus is the muscle which is helping up to climbing stairs, sitting up from the postures. So if these particular muscles are kind of paralyzed, the persons are in a having difficulty in climbing stairs, getting up or getting up in the bus or getting up from the chairs, climbing upstairs, etc. etc. Sciatic nerves, like largest and the thickest nerve of our body, can be divided into two parts: tibial nerve, common peroneal nerve. So this particular sciatic nerve have got like a no branch whatsoever in the glute region. It supplies beyond the glute region and supplies this particular hamstring muscles, and then it goes to this particular popliteal fossa region and then go to the back side of the thigh region. So this particular sciatic nerve commonly gets injured if you have a faulty injection procedure. So in this gluteal region, which is a domain for the giving intramuscular injections, has to be chosen correctly, like with this particular quadrant. So if you divide this particular hip joint into 4 quadrants, out of this, upper outer and lower outer quadrant is safer for giving intramuscular quadrant. Inner side, like inner upper or inner lower, if you are giving the intramuscular injections, there are chances of getting this particular drugs or needle injury to this particular sciatic nerve. So intragluteal injections or intramuscular injection in the glute need to be taken care. It should be given in the superolateral compartment, which is the best one to give upper and outer quadrant. If not, then also we can just like give into the lower outer quadrant, but we cannot go into inside of it. So this is what we have to keep in mind regard to this particular like muscles, and these small muscles which is known as supplied by gemella superior inferior, supplied by this obturator nerve. You should be knowing the names of it, and the actions of the gemella is like a lateral rotator of the hip joint. Likewise, this particular nerve to quadratus femoris, which is also like a lateral rotator. Now coming over here, we have a nerve, we call them a pudendal nerve, which is basically supplying the groin region, present in this gluteal region. So comes briefly into this particular, enters to this gluteal region through this particular greater sciatic notch or greater sciatic foramen, leaves this particular region through the lesser sciatic notch and enters to the pelvis, and after reaching to the pelvis, they supply the perineum and the pelvic viscera. So this pudendal nerve is also present as a content of these regions. Coming to the blood supply, which is coming from the branches of the iliac arteries, internal iliac of course giving the branches superior, inferior gluteal and as well as internal pudendal artery. They supply this particular blood supply to this particular gluteal region or back side of the hip joint over here. They supply this, making two anastomosis. We call them as cruciate and trochanteric anastomosis. Along with that, we have the internal pudendal artery, which is not supplying anything whatsoever. It following the pudendal nerve, reaches to this particular perineum or groin region and supplies there. But it runs through this particular region, internal pudendal artery. This internal pudendal artery and the pudendal nerve may be seen as a content of this ischiorectal fossa present on the lateral side of it. Cruciate anastomosis, you should be knowing this particular branches, whatever is contributing to cruciate anastomosis, like inferior gluteal artery or climbing branch of first perforator, lateral and medial circumflex coming from the sides and making a cross or like this. That's why they are known as cruciate anastomosis. Trochanteric anastomosis, they are held in this particular level of the greater trochanter, which is present on the side over here. They are contributing by this particular superior inferior gluteal and circumflex and medial and lateral circumflex branches. So they basically supply this particular back side of the hip region. Back side of the thigh is principally supplied by this particular perforator branches of deep artery of the thigh. That means arteria profunda femoris gives this perforator branches, perforates this adductor magnus and reaches to this posterior side, and then the anastomos along with this particular long axis of this particular like a femur and supply this entire thigh region. We do not have any dedicated artery to the branch of here, only the perforator branches supplies to this. Fracture of the hip, many a times we ask about these particular questions, like if you have the hip fracture which is involving in this particular region, which is known as the neck of the femur, which most commonly gets damaged. If you have the neck of this particular femur is damaged, we have a chances of this particular avascular necrosis of the neck region. Reason is that this particular blood supply to this particular region will be cut off if you have a rupture over here, because the blood supply from here comes through the retinacular branch of these particular arteries, which is supplying the head region. And then we have this particular regression of the blood leading to this particular lack of blood supply, leading to the loss of head. So this avascular necrosis, which is common, that we keep in mind regard to the explain why kind of question. Coming to the popliteal fossa, we have to know the boundaries of it, like upper boundary, lower boundary, and the content which is holding this region is popliteal vessels, and the artery and the nerve which is present in here is a continuous or sciatic nerve which splits into two branches. We call them as tibial and the peroneal nerves. They are going to supply the deep muscular branches, and they are going to supply this particular muscle in the back of this particular leg region and front, and as well as the muscles in the foot as well. Popliteal artery, which is a continuation of this particular femoral artery, and this particular popliteal artery comes to this back side through this opening. We call them as adductor hiatus, which is present in the level of adductor tubercle or just above the adductor tubercle in the femur. So this popliteal artery splits into two terminal branches. We call them as like tibial branches. We call them as anterior tibial, posterior tibial. Posterior tibial remains in this particular posterior compartment. Anterior tibial moves into the anterior compartment and supplies this particular anterior part of the things. They make an anastomosis around the knee joint. We call them as genicular anastomosis. Popliteal vein, which is continuation of the femoral vein, which is basically continuation of the popliteal veins. Tibial veins. Tibial veins, anterior tibial, posterior tibial unite to form this popliteal vein. Remember, this popliteal veins receive a superficial vein which is known as the small saphenous vein in this particular popliteal fossa, accompanied by a nerve which is known as sural nerve. Lymph node, as I have mentioned, popliteal lymph node present over here. They drain this particular back of this particular like a leg region or back of this particular foot and as well as leg region. Okay, quickly on the leg region of tibia, we have to know about this tuberosity, what attaches over here, and like the significance of that particular structure attached, which is related to the knee joint reflex that we nonchanagare areas. Eta battery test surface. Yes. Coming to this part, we have this particular leg compartment as well, like the thigh compartment, and it is split by this crural fascia, posterior compartment, anterior compartment, and lateral compartment. And this particular region, we have the muscles, of course, that you have to keep in mind regard to this particular front compartment of the leg. Tibialis anterior, femoralis longus, which is present on this particular lateral side. In between them, we have this extensor digitorum longus, and deep to that, like extensor hallucis, which is present in the deep region going to the hallux. And along with that, we have this particular lateral compartment which holds this particular fibularis longus, fibularis brevis, and fibularis tarsus. So if you just like take out all the muscles, tibialis anterior, extensor digitorum longus, extensor digitorum longus, deep to that, extensor hallucis longus, which is the three muscle present in the front of the leg. And on the lateral side, we have this particular like fibularis longus, fibularis brevis, which is the lateral compartment muscles which are present in this particular region. So this content we already have learned about, or some of the muscles of the foot which is out of it. Extensor digitorum brevis, which is present in this particular foot region, often prominent in the footballers or soccer players. They are present as an important landmark structure. Now coming to the lateral part, we call them as peroneal compartment, has got two muscles which is known as peroneus longus or fibularis longus and brevis. This particular compartment we call them as everter compartment. So this particular inversion and eversion movement takes place in the subtalar joint, and this subtalar means this is the talus, under the talus and the and between this talus and calcaneum we have this particular joint. At this particular joint level, we have this inversion and eversion movement taking place. Inversion, which is done by this particular back muscle which is present in the leg region, as well as front muscle present in front of the leg region, whereas the everters are solely contributed by this particular peroneus longus or fibularis longus and brevis. So this content that we have to understand on these particular leg regions. The muscles in the front, muscles in the lateral side. Now muscles all in the front side is supplied by this deep fibular nerve, and muscles in the lateral part which is supplied by this superficial fibular nerve. They are branches coming from this tibial branch of femoral sciatic nerve, which is going to supply this particular supply to these particular regions. And this innervations that is broken down into this particular two thing. Into this, we have seen the sciatic nerve, which splits into common fibular nerve and as well as tibial nerve. Common fibular nerve splits into two branches, which is known as superficial branch and the deep branch. And this particular tibial nerve reaches down into two branches, superficial, which is going on this particular posterior tibial or tibial nerve, which is going on the back side, and it gives a branch which is going in the front side, which is known as deep fibular branch, which is going to supply this particular the front side of the anterior compartment leg muscle. The main continuations of the tibial nerve goes to the foot region, which splits into two branches, medial plantar and lateral plantar branches. So this is the breakdown of this particular schematic branch which is present in this region of the branches. So superficial peroneal, which is going to supply the peroneus longus brevis, that means E vertebra of the foot and supplies the skin, of course, and the deep peroneal branch, which supplies the deep peroneal branch, which supplies this anterior tibial compartment, which is going to supply the tibialis anterior, extensor hallucis, extensor digitorum, which is going to end by this particular supplying the knee ankle joint and supplies this first wave space. The main continuation, which is known as this particular the tibial branch, which is going into this particular back side, which supplies this particular skin in this particular region, the back side and lateral side of the skin, which is supplied by this particular muscle, which is coming in this. So common peroneal branch and these branches have got like this innervation that we just have to quickly overview. And moving to this particular arterial supply, which is the same popliteal artery splits into posterior tibial artery and the fibular artery. They are going to supply in this particular regions, and anterior tibial artery supplies the front compartment, which is kind of continued as the arterial dorsalis pedis. Arterial dorsalis pedis present in the first wave space, should be palpable in individual. If it is failing to palpable, arterial dorsalis pedis indicating arterial disease or arterial infections, which is known as this renal syndrome or kind of things, which is known as change what backside the eight. Posterior compartment of the leg have got muscles in the superficial and deep plane, gastrocnemius soleus, and the gastrocnemius soleus deep to that we have this muscle which call them as a tibialis posterior, which is the deepest most, and along with that flexor hallucis and flexor digitorum present on this particular lateral and medial side as well. The flexor hallucis, which is great toe, goes to the great toe, present on the lateral side, and the flexor hallucis, which is going to supply flexor hallucis digitorum, which is present on the medial side. So whenever you are identifying this particular deep muscle in the break region, so you have to identify it correctly. Coming to nerve supply to this posterior side, all the muscles which are present in this posterior side supplied by the tibial branch or tibial nerve, which is a continuation of this particular sciatic nerve, which is going to supply all this gastrocnemius soleus, plantaris, popliteus. Eventually they go to the lateral and medial plantar nerve, supply all the muscles of the sole region. So four sole region muscles are there. They are supplied by this particular tibial nerve. Back side we have the same popliteal artery, which splits in the posterior tibial and anterior tibial. Posterior tibial remains in the back side, anterior tibial moves to the front side and supplies likewise. And posterior tibial pulse, which should be felt at the back side between this particular medial malleolus, which is present in the front side, and the calcaneum or tendocalcaneal part, middle point of that should be palpable like that. Not easy to identify this like arterial dorsalis pedis, but if we have to really take care of this particular pulse in this region, that should be searched in this particular midpoint between this posterior margin of the lateral malleolus. Posterior margin of medial malleolus and this tendoachilles. Coming to the foot, we have this fascia, we call them as plantar fascia, And this plantar fascia, likewise we have the palmar fascia, which is present in this particular region, supplies the deep muscles on this particular foot region. Now foot consists of this particular muscles, which is known as this particular like calcaneum, talus, navicular, and this cuneiform, three of them, and then we have this metatarsal and the phalanges which is present to it. Now out of this particular talus, that you have to keep in mind, this particular talus do not have any muscle attached to it. So and calcaneum, which is having this particular prominence on the posterior side, we call them a posterior tubercle of this calcaneum, which attaches to this particular tendo Achilles in this region. Coming to the arches, like we have like two arches present. One is longitudinal arches, medial and lateral, two of them, transverse arches. They are present in the front side and the back side. They are holding this particular foot, holding the dome of the foot, keeping this particular thing up. So this particular arch is making this particular foot in a position so that this particular foot can be just like running in this particular region, walking in this particular region, devoid of hampering the blood supply, nerve supply, which is present in it. So these arches are creating this particular blood flow to this particular sole easy, and as well as this particular blood supply and nerve supply to this particular muscles easier, so that this particular region, whenever you are walking, standing or running, this particular blood supply to this particular region remains like it is. So we are not going to talk about detail about this particular like arches of the foot. So we just like skipping, because I say basically descriptive part that we just like can skip through. And moving to this particular from here, there's muscles on the sole region of the foot. 4 sole muscles are there. Also like do not have that particular undergrad importance. I'm just like skipping this part as well. Coming to this blood supply, plantar artery, medial plantar, lateral plantar, they mix an anastomosis in this region. I'm skipping that part as well. Now coming to this joint anicula. So mostly we see this particular joint questions which is involving this region in the lower extremity, hip joint and knee joint commonly surfaces with so hip joint is contributed by the acetabulum and this particular like a head of the femur, which is basically united by this number of ligament which is holding this particular regions. And this region we have to know about little bit detail of it, the blood supply and etc., which is related to this particular hip joint. So starting from this particular supports of the hip joint is we have the strong capsule which is present on attached on the acetabular margin, as well as this particular bony margin of this neck of the femur. And this particular capsule is strengthened externally by the ligament. We call them iliofemoral ligament, pivofemoral ligament, ischiofemoral ligaments. They are basically strengthening the capsule. Deep to the capsule, we have this particular synovial membrane which is present to it. So this particular region has a blood supply coming from the lateral and femoral circumflex arteries, which is a branch coming from the deep artery of the femora or artery profunda femoris. Nerve supply coming from the obturator nerve and the femoral nerve, and as well as twig of the sciatic nerve which is supplying to this particular region. Now this particular ligaments which is present in this particular region like ischiofemoral coming from the ischium and spiraling around covering this particular joint and strengthening this particular hip joint capsule. We have another ligament, we call them as iliofemoral. It looks like a Y coming from the ilium to this particular femur. They looks like split Y like this. They have a longitudinal and oblique band like this. They are holding this particular capsules of the hip joint like this. And then we have this flat quadrangular tendon. We call them spivofemoral ligament. So these are the 3 ligaments. They are, you have to mention about whenever you are addressing this particular supports or structural integrity of the hip joint, whenever you are like asked to explain about these particular regions. Dislocations of this particular hip joint is pretty much common. That means this particular head of the femur moves out of the acetabulum. It may move posteriorly and may move anteriorly. The posterior dislocation is more commoner, which is happening and moving this particular head on the posterior directions if we have the trauma which is coming from the anterior directions and can reach from the back side. And if it is moving backside, the sciatic nerve may be damaged in this particular region as because the moving head. So it may cram this particular sciatic nerve into this region and damage this particular sciatic nerve. If this particular sciatic nerve is compressed, it lead to this particular paralysis of the muscles of the all the back muscles in the thigh region and as well as back of the leg region, leading to the foot drop, which is common in case of the posterior dislocations of the hip joint. In case of the posterior dislocation, this ischiofemoral ligament, which is reinforcing, spiraling around, may be damaged, may be teared. So we have to reduce this particular thing and repair this particular ischiofemoral. Ischiofemoral ligament is a kind of like MCQ. Sometimes they ask about this particular MCQ, like which ligament likely gets ruptured in kind of like the posterior dislocation, which is ischiofemoral out of these three ligament that we have mentioned. Anterior ligament, less common, moves this particular head of the femur anteriorly, lies into this particular pubic region and acetabulum region. In this region, if you have the damage to this particular pubofemoral ligament, the pubofemoral ligament damage leads to this particular anterior dislocations of the hip joint. Now, related to this knee joint, you have to know about knee joint, which is like having this kind of bony articulation which is coming from the lower end of femur and upper end of tibia, which is known as the condyles of the femur and tibia, making this particular joint extension and flexion possible. Like any synovial joint, they have a capsule. In between this particular capsule, we have a cartilage present in here. We call them as cartilages as the menisci. Now we have this particular fluid which is present in here. So supports of the knee joint, we have this synovial membrane, and along with the synovial fluid, then you have the capsule around, which is known as capsule of the knee joint. So articular capsule, which is thin and weak in case of this particular knee joint. Now this particular capsule of the knee joint is reinforced by some kind of external ligaments, which is known as this particular collateral ligaments, medial collateral and lateral collateral ligaments. Along with that, we have the intercapsular ligament, we call them as cruciate ligament, which is running crisscross anterior cruciate, posterior cruciate, and holding this particular region as well. Coming to the blood supply to this particular regions, which is supplied by the genicular arterial branches, supply this particular region coming from branches, and nerve supply of course is coming from the obturator nerve and the branches of the femoral and sciatic nerve also gives a tweak to this particular region. Coming to this particular locking and unlocking, so whenever you are standing in position, there is a rotation or gliding of this particular medial condyle over this particular femur, over this medial epicondyle of the tibia, making this particular joint in a locked position. This particular locking helps us to remain and stand in positions, and this particular locking is a kind of like a preventive reflex for falling down. Whenever we start moving, we have to unlock. That means we have to pull this particular medial condyle of the femur laterally, which is done by the contraction of the popliteus. So popliteus is considered as a unlocking muscles, which comes as a short note, etc., etc. So locking and unlocking movement, which is maybe related to this. Coming to this particular ligament that we have mentioned, medial collateral, lateral collateral ligaments, they are reinforcing these regions over here. Out here, clinical importance to this particular medial and lateral collateral ligament, they are prone to have injuries. So this particular medial collateral ligament and lateral collateral ligament, we have to know about that. Tears of this particular medial collateral ligament is pretty much common than that of lateral collateral ligament. So if you have a blow to this particular medial collateral ligament, we may have a chances of this injury to this medial collateral ligament. We call them as MCL tear, that may be associated with the anterior cruciate ligament tear. At the same time, the meniscus may be damaged. If you have this particular three things happening, like MCL tear, anterior cruciate ligament tear, and the meniscal injury, we call them as triad of injuries. So this particular triad of injuries commonly happens in case of this particular sports injuries or any kind of like road traffic accident, which involves this particular cruciate ligament, anterior cruciate, medial cruciate, posterior cruciate ligament. Likewise, this particular lateral cruciate ligament may have a damage as well, which is present on this side. But this lateral cruciate ligament is stronger than that of medial collateral ligament. So if you have this particular isolated lateral collateral ligament damage, which is relatively uncommon, I would say. So to test this particular ligament injuries, like we take this particular valgus and valgus test, that means we twist this particular angle, see this particular injuries if it is there or not. Cruciate ligament, anterior cruciate and posterior cruciate, they are just like known as ACL and PCL. If they are damaged, we call them as Droyat test. So this particular anterior cruciate and posterior cruciate, if it is damaged, then we have this particular thing assessed by this particular anterior and posterior cruciate drawer sign. So we ask this particular patient to flex the knee and pull these things. If you have anterior cruciate ligament damage, it should be moving out. That means makes this particular knee joint really unstable. If you have posterior cruciate ligament damage, you press this particular knee joint back side, and then we see that if it is a loose lax, then we say that posterior cruciate ligament damage. Now, little bit about this particular anterior cruciate and posterior cruciate. You should be knowing about this particular anterior cruciate ligament and posterior cruciate ligament attachments, etc., etc. So, this particular ligament we call them as intercapsular ligament. That means they are present inside the capsule. The anterior cruciate ligament starts from the anterior side, moves in the posterior side and to the left side. So, this particular ACL and the PCL need to be identified or need to be addressed. So, attachments of this particular anterior cruciate ligament is present in the anterior intercondyle area of the tibia, and it moves to the medial side and attaches to the lateral condyle on the lateral part of the lateral femoral condyle. And this particular anterior cruciate ligament is holding this particular knee joint in a position so that this particular knee joint, if it is dragged anteriorly, it is resisted. Posterior cruciate ligament, which is present in the opposite region, which is present in the posterior intercondylar area, and this thing's moving laterally and attaches on the medial surface of the medial condyle of the femur. Functions of the posterior cruciate ligament: if we have to press this particular knee joint posteriorly, this posterior cruciate ligament resisting it or resisting this particular posterior rolling of this hip joint. Now, this anterior cruciate ligament and the posterior cruciate ligament are most commonly are sports injury other than this road traffic accident. Out of this posterior cruciate and anterior cruciate, the ACL injuries are more common than that of posterior cruciate injuries, ligament injuries. So, these are the a little bit more contributing things related to this particular knee joint. Coming to this particular menisci, which is present in this particular knee joint, you have to know there are two of them, medial and lateral menisci. This particular menisci is kind of like a fibrocartilage. That means once damaged, they cannot be replaced. Once again, out of this particular medial and lateral cruciate ligament, medial cruciate menisci are prone to have injuries because they are fixed in positions, whereas the lateral cruciate ligament can be hidden by this particular movement of the popliteus muscle and covering of the lateral collateral ligament. So, this particular thing, if this particular menisci and as well as anterior cruciate ligament and as well, if you have this particular medial collateral ligament damage, we call them as unhappy triad of the knee. That means three of the components are damaged: anterior cruciate ligament tear, medial collateral ligament, also known as tibial collateral ligament damage, and medial meniscus damage together torn, which happens in most commonly in case of this sports injuries, are known as unhappy triad of this particular knee joint. So, it's a kind of rule of things is that if you have damage to the medial collateral ligament, there is also damage to this anterior cruciate ligament, and if this anterior cruciate ligament is damaged, we have a damage to this menisci. So, these are things kind of like things which is happening in the sports injuries. And little bit about bursas, which is kind of like supports present in front of the knee joint. Out of that bursa, which is like a membrane filled with this particular fluid present and as a cushion around this particular friction point of this particular knee joint. Of that, we have this suprapatellar, prepatellar, and this particular popliteal bursa. Out of that, suprapatellar bursa is kind of like a prominent bursa which is present in this particular region, as well as subcutaneous bursa which is present in the prepatellar region are kind of like a prominent bursa. If we have infections to the bursas, we call them as bursitis. So, suprapatellar bursa, if it is probably like common bursa which may be like damaged because of the frictions, we have this particular pain, tenderness in front of the knee joint along with the swelling. So, the suprapatellar bursitis is a kind of like a problem which is happening because of the infections or friction injuries to this particular front of the knee joint. So, plain hip joint X-ray and knee joint X-ray, whenever we are given in examination, you should be able to identify the knee joints in a sciagram plate, like what are the different bones which is present, where exactly this particular knee joint is there, which is the knee joint position, and what contributes to this particular knee joint. What are the other bones which are visible, like what are the other joint as well is visible in here, should be able to identify. So, these particular points or markers we may be given with it and ask you to identify about knee joint or different types of like a radiological question based on the knee joint, based on the ankle joint likewise. So it's a kind of MRI picture, is kind of like a CT scan, X-ray picture of the knee joint. So knee joint, ankle joint. And ankle joint, we again asked to identify this, just like bones which are present in it, like talus, calcaneum, lower end of the tibia, fibula, etc., etc. They are pretty simple, easy question we usually ask. Similar to this particular foot joint, like foot X-rays, we give to identify these different types of bones which are present, like calcaneum, talus, navicular, etc., etc. Should be able to identify in this particular diagram pictures like this. So these are the things that you have to keep in mind. The arteriogram questions, normally you do not give it at this particular undergrad level. Hip joint, again, you should be able to identify this particular hip joint. So this particular joint, symphysis PV, sacroiliac joint, which is right side, left side, which is present. Hip joint, right side, left side, should be able to identify hip bone, parts of the hip bone, etc., etc., obturator foramen, etc., etc., which we should be able to identify. The disease or pathologies we normally do not give it to identify in examinations. So these are like a quick brief review of the lower limb.